Well, thank you, Brad, for the introduction. I want to welcome the applicants. And training surgeons is something that I've really thought about for a long time. And at times when I was a trainee myself, there were things that I enjoyed and there were things that I did not enjoy. So hopefully I can touch on, a new concept of training surgeons like other disciplines. This is my disclosure slide, and it has no bearing on this presentation. So when you see a picture that has people like these, most associate this with being gifted, being a genius, working hard, sure, but then having some innate abilities that made you so successful. And I think even in surgery, when you see a surgeon, I mean, most of you don't recognize this gentleman. He was my partner in Fresno. He's the past president of ASMBS, and if so, he's the one who actually first developed laparoscopic hand-sewn Roux-en-Y gastric bypass, first surgeon to ever do it under 2 hours, under 1 hour. Everybody thinks of him as a gifted surgeon, that this is just his innate abilities. If you see him operate, it's flawless. And I'm going to try today in this talk to convince you that being gifted is not everything. So years ago, Sir Francis Galton published this book talking about being a genius and being gifted, and that if you do something and you're good at it, it's because you have some innate abilities. And it was this natural ability that has been touted for years. But today I want to introduce you to the science of deliberate practice. This is actually a science. Who you see in the picture here is Anders Ericsson. He's a professor of behavioral psychology in Florida, and he's actually one of the pioneers of this science of deliberate practice, that you can take someone from point A to point B really regardless of their innate abilities. You can get them to be an expert by a certain way. Most of you must have heard of the 10,000 hour rule, and it was popularized by Malcolm Gladwell. But deliberate practice is not about time only. So 10,000 hours doesn't do it. It's not about spending 10,000 hours doing something. It's about the way by which you spend the time until you get to the end of the 10,000 hours. And today I want to introduce you to something in music. So for instance, there's a very famous study that they did in the 90s called the West Berlin Violin Student Study. And I like that name because the most important study in bariatric surgery is called the Swedish Obesity Subject Study. It's very close to the name. And in this study, they went to West Berlin to one of the elite schools of music, and they chose a few professors and asked them to name the best 10 violinists they have in their school. And then they asked them to name 10 violinists in the school that they think they're average, they're struggling, they're not doing great. And then they went to an average music school in West Berlin that is not really an elite school and had 10 students chosen. Now, they didn't call them the 10 worst violinists. They were nice. They called them the music teachers, because they thought these are the guys or the girls that are going to just end up being music teachers at schools. They're not going to make it into being a real musician. And then they went into West Berlin and chose from the music orchestra 10 of the best accomplished violinists in that time. And they wanted to do this study, and the study was called The Role of Deliberate Practice in Acquisition of Expert Performance. They wanted to see if there's a way you could actually correlate what makes you among the 10 best versus the 10 worst, and what makes you a very accomplished violinist overall. As you can see, Anders Ericsson was the first author of that study. And they spent weeks with these 40 people. So they asked them first, when did you start practice? They had interviews with them about the methods, how many hours per week, did you keep diaries, can you tell us from your memory? They asked them to tell them exactly how many hours per week and how many years they practiced from the first time they ever picked up a violin. They asked them if they participated in competitions. Then they asked them to keep diaries for 6 weeks. And they asked them to try to correlate the diaries they kept with their memories of what they did when they were playing for years. And then they had 10 specific tips in playing the violin. For a surgeon, it's not tying maybe, it's suturing, it's maybe that they asked everyone to try to see and gauge where they are. And then finally, they asked them if they had fun when they practiced. And they felt this was actually important because many people think that grit is doing something that you don't necessarily enjoy, but you just keep at it and keep doing it. So they wanted to know if these people, the ones who practice for hours, did they practice for hours because they enjoyed it or because they had a goal in mind that they wanted to actually reach? So they found, as expected, is that most people spend more leisure time on Saturday and Sunday. So that's not really unexpected. They found that when did you start correlates where you end up. So if you started very early, if your parents actually got you introduced to playing the violin very early, that was the most predictor of where you ended up. So if you start very, very early, you had the best performance. So just chronological, being involved in playing mattered. They also found that the best students could match their diaries. So their memories really matched what they did in the 6 weeks when they followed them. While the others, it didn't match very well. They're kind of confabulating. They're saying, I was practicing for 10 hours. They really weren't. When they had the 6 weeks, that was not their typical week. But they found that if you look at the age of the pianist over time, and here they included some pianists and some violinists, the expert was the person who had very long years. Not only that, they came up with this hours of practice. And this 10,000 hour was born by the fact that by the age of 20, the ones that were experts had spent 10,000 hours playing. So that was the reason this 10,000 hour was born. And when you read books that Anders Ericsson wrote, he does not think from their group that the 10,000 hour is the trick. And that's what I'm going to talk to you about today. But they also found that if you look at the music professors and the best students, their curves match. But it matched mostly because of the years they practiced. And the ones that were considered worst students or mediocre just had not practiced for long hours compared to the rest. So let's take something like running. Many of us run. You could have someone who runs 3-4 miles a day. They run every day. They run for 10 years. But they don't necessarily improve. They run the same way. And the reason is, to improve, you need to have a goal. You need to have a coach. Someone has to tell you, you're not moving your hands right, your trajectory, the way you run, you're not breathing right. So you need to actually have what we call deliberate practice. So the idea that Anders Ericsson and his group introduces that to improve, you need to practice outside of your comfort zone. So if you're a resident or a student that always stands in the back and makes sure that the questions never get to them, you're not going to improve as much as staying at the front and asking questions. You might be uncomfortable, but that's actually where the improvement happens. Then the second thing is you have to have very specific goals. So you can't just start practicing not knowing what are you trying to reach. You have to focus when you practice. It doesn't have to necessarily be fun. And you have to get high quality feedback. I think that's extremely important. It has to be done by a coach, by someone who can recognize if you're doing well or if you're doing poorly, and can recognize when you're doing poorly what's the reason you're doing poorly. They can actually pick up on certain things that make you not very effective. And then the last one is the most important. You have to have a mental model of the goal. You can't reach something if you cannot put it in your head first. So you first have to have in your head, what are you trying to do? And then you practice to try to reach it every time. But the most important thing is to have that mental model. So let me give you an example. So let's say if you're putting, you've never played golf before, someone give you 100 balls and you're putting. By the time you reach the 80th ball, the ball is getting pretty good and you're kind of getting into a rhythm and you can get it close to that hole every time. But if we block that hole and we give you 1,000 balls, you will never improve. Once we take the feedback away, you don't improve. So feedback is extremely important. And one of the most important things is the feedback has to be objective, meaning subjective feedback that is born in telling you that you're not good, you're inadequate, is not very helpful. It has to be done by a coach, and the coach has to be very good, as I said, has to know what is good, what is bad, has to recognize when you're not doing something right, not get frustrated, and know exactly what's the reason you're not doing it right, and can actually point you to what you need to do. But then the most important thing, you have to have a mental model, and you have to practice on your own. And this is one of the most fundamental things that musicians do. Any one of you who played the piano or was involved in music had time with their teacher, but then they had plenty of time in the week alone. And this is where an expert is born. It's not being gifted. It's being able to spend that time alone with specific goals, knowing exactly what he's trying to do, and having a mental model about it. And then finally, the feedback could never be uneducational. When you meet with the teacher every time, there has to be a way that actually is very educational to get you every time interested. So the mnemonic that I thought about was that practice has to be focused. Feedback that's objective by a coach. You have to spend a lot of time working. There has to be specific tasks every time. It has to be an educational environment, and that's what actually creates deliberate practice. So let's take, for instance, learning. Many of us learn something and we become competent at it, and you want to be competent at it. There are 4 stages of being competent. So in the first stage, you're incompetent and you're unconscious about it. If you told your 3-year-old, can you drive the car, they can't even reach the gas, but they're willing to drive the car. They can drive it. They'll tell you, sure, put me on the driver's seat, I'll drive the car. So they're incompetent, but they're unconscious about their incompetence. And if you ask your 11-year-old, can you drive us? He or she will tell you, I'll probably kill you guys. No, I can't drive. It's dangerous. So both are incompetent, but the 11-year-old is conscious about the fact that they're incompetent. Now, if your 16-year-old has just gotten the driver's license, they are so stuck that they don't want to even talk to them. Yes, they can drive, but they're very conscious about every single move. And then we text and drive all the time. Now, why is this important? For a surgeon, you are the most dangerous in the last stage. When you can go through the surgery without thinking, that's the most dangerous part. You become complacent, it becomes easy, and that is why operating within a team is so, so important. Because you could have someone in the team, this is their first surgery, they will recognize when they have met with that patient before surgery and the patient said, I have a hernia in my left groin. To you is just one of the 5 hernias you're doing today, and you've done hernias for like 15 years. So when you become competent and you become unconscious about that competence, you are actually the most dangerous. So what does this have to do with surgical training or bariatric surgery for that matter? So you've always been taught, and William Halsted is one of the pioneers of surgical education, is see one, do one, teach one. That's everywhere, right? But when you see one, you actually don't see one. You see way, way too many. And when you get to do one, there's very little feedback most of the time on what you have to do, at least many times when I was a trainee. And there's a lot of frustration for the person, for the staff. It makes you feel inadequate. You think like, what, it's just me who can or can do it. And let me tell you why this is important in bariatric surgery. This is a curve that shows the bariatric operations in the US. So you can see in green a procedure that's actually the most known procedure with the best outcomes, been around for 50 years, Roux-en-Y gastric bypass. You can see the numbers everywhere in the world is going down. I can tell you it's not going down because the procedure has bad outcomes. There's no time today to show you all the literature, but this is the procedure with the best 30-year outcomes in terms of weight loss, comorbidity resolution. We've shown that it decreases heart attacks, makes people less chance to die. You can see a procedure in yellow that started in 2000 is like taking over, sleeve gastrectomy. Even though sleeve gastrectomy, we only have 10-year outcomes, we know it has Barrett's incidence in double digits, 13 to 18%, and a significant weight regain problem. So why is the picture like that? You can see gastric banding in orange going away. So the reason is because to master laparoscopic Roux-en-Y gastric bypass, it's a very difficult task. It has a very steep learning curve. And to create a small, short pouch and have a jejuno-jejunostomy laparoscopically and to get jejuno-jejunostomy, I mean, I can just tell you the task is difficult. And I really think the reason it's becoming very unpopular is not because it's not effective. It's because it's difficult to learn and master and get good outcomes with it. So if you compare three procedures, so on the right, sleeve gastrectomy, where we remove 3/4 of the stomach, no work on the small intestine. In the middle, a procedure called one anastomosis gastric bypass that's not allowed to be done in the US because we don't have outcomes, but it's the most common bypass everywhere else in the world. You just basically do a B2, and the gastric bypass where we have to do 2 anastomoses. I think you can compare them to the scooter, a skateboard, and a ripstick. One, there's resection with no anastomosis. Must be easier to do. There's no intracorporeal suturing. The second, you work only above the colon and you only create 1 anastomosis and you don't close any defects. In the third, you have to, in the Roux-en-Y gastric bypass, you have to actually do resection, anastomosis above and below the colon. You have to close 2 mesenteric defects. So surgeons compare them, but they are not compared in terms of acquisition of the skill. So the learning curve of the three is very, very different. And you can look at laparoscopic colectomy. The COST trial in 2004 has shown us that laparoscopic colectomy for cancer is not inferior to open colectomy. But you can see the adoption rate of laparoscopic colectomy despite all the efforts of the American Society of Colorectal Surgery. You would think that maybe 80% of patients would have it. But it's because it's, again, not an easy procedure to master. And if you do 10, 20 cases in the year, you're not going to spend the time in those 10, 20 cases trying to learn. So why is creating an anastomosis below and above the colon such a difficult task with such a steep learning curve? Let me explain. So just for illustration, we're just going to take creating the jejuno-jejunostomy and closing the defect. Because this is the one thing that sleeve gastrectomy doesn't have, one anastomosis gastric bypass doesn't have, but Roux-en-Y gastric bypass has. That's the extra step a surgeon has to do. Okay. So one, port placement. So if you don't place your ports in the right place, you can't do surgery. I work with many residents, and this seems foreign. But let me give you an analogy. None of you does an open appendectomy through a right upper quadrant incision. Well, why not? Because it's in the wrong place. I can't see. It's the same thing. If you try to do a procedure and your visual camera port is very far from the target organ, the procedure is difficult. It's not that the patient is difficult. You're putting the ports in the wrong place. So port placement is the most important art a laparoscopic surgeon can learn. The heavier the person, the more difficult it is, because as you get heavy, your liver is bigger, the intra-abdominal organs in a different place, your umbilicus recedes, so surface anatomy becomes different. And if you're standing like the gentleman on the right, stooped over like this, you're very tired at the end of the surgery. It's not because the surgery is difficult, because your ports are in the wrong place, and that's why it's difficult. Now, second thing is intracorporeal suturing. Most trainees have trouble with intracorporeal suturing because it involves using the non-dominant hand. It involves looking at a 2-dimensional screen while the inside is 3-dimensional. It involves the right hand helping the left hand. So one of the nurses told us that we are a dominant hand advocate in the OR. We try all the time to advocate for the dominant hand because the non-dominant hand is not helping it. That's what we do in the OR. Most of you struggle in the OR because you're not used to your left hand working with your right hand. And intracorporeal suturing is a technique. Both hands have to work together, otherwise you can't do it. There are 2 defects you have to close, and one of them is at the jejuno-jejunostomy, and it's below the colon. So if you have put your ports in the upper abdomen, when you start that, you're already looking down or backwards. The surgery is already difficult. It's not because the patient's BMI is 50. It's because you place your ports from the beginning wrong. Then surgeons started doing Roux-en-Y gastric bypass retrocolic. The distance was very close. I mean, many surgeons who do cancer surgery know that retrocolic, retrogastric is a very short distance to the GE junction. Then surgeons had internal hernias, and with the law of unintended consequences, they moved to anticolic to decrease internal hernias, but they introduced tension that no one recognized, made the surgery a little bit more difficult. And the final thing is our patients are getting heavier and heavier. And we're not making adjustments to the way we place ports or the way we actually go about taking care of the procedure. And that's why just creating a jejuno-jejunostomy below the colon becomes a difficult task and closing that defect. And it becomes so difficult that a person could have complications in their patients and decide that, you know what, this procedure I'm not going to do. And it's not because the procedure is not effective. So this is a very elegant randomized controlled trial from Sweden where they randomized 2,500 patients. For the applicants and their young residents, to randomize 2,500 patients is not easy. It's a very difficult task. And they did this in more than 10 centers. And what they did is they asked everybody to close the defects or leave them open. You can see initially in green, the patients that had their defect closed had more obstructions, but over time had a much lower internal hernia rate. You can see the people who didn't close initially had less obstructions and over time had more internal hernias. Why did they have obstructions at the beginning? Because to teach someone to close the defect, there's a learning curve involved. So the surgeons who did not close the defects and started closing them were having problems of closure because it's technically not as easy. But it's clear that if you do a Roux-en-Y gastric bypass, you have to close the defects. Yet many surgeons today don't close the defects because it's just easier not to close the defects. So what's the solution for these difficult tasks? I can tell you, it is not robotic surgery. So the solution is we have to really work on specific way of actually teaching people. So let me tell you about focused deliberate practice that we try to do for our fellows in the operating room. So we try to make sure that they get feedback, they get objective feedback. We try to act as their coach. We give them time in between that they have to go to the simulation lab with structured training of what they have to do. They have to do it before they start. They have to do it in between sessions. So if we operate on Monday, I expect that between this Monday and next Monday, they'll spend time. Then when they come in the OR, they get to work and there's objective feedback on what they're doing, how the stitch is. You know, do you have to turn your wrist back more? Where are you grabbing? And things like that. And then we try to make sure that there's goals with each procedure. And what we try to do, for instance, is the person starts the case and they have an hour to put the ports, run the bowel, divide the bowel, do the JJ, and close the defects. And when the hour is up, they have to give up the case. So there is incentive for the person to try to practice, and they're working on their own. And actually, it does work very well. So every week, you can see improvement. And then you make these tasks into something that can actually be done. Let me just show you videos of two parts that we talk to people. But before I do that, let me talk to you about port placement. So we never placed the first port in the midline because we want to look on the inside. So first port always is at Palmer's point in the left upper quadrant. Then we look on the inside and decide the camera port based on a 45-degree angle from the target organ, regardless of what the target organ is. So we pick on the abdominal wall a location that gives us an imaginary 45-degree angle from the GE junction. So we use the edge of the liver to actually decide that, like so. So if you put the ports too high, you end up looking down or looking backwards. And every port is placed at an angle, so the outside and the inside create a valve effect. Every port is placed by looking at the inside anatomy. So you could have the first patient where the camera port is 5 centimeters from the umbilicus, the second patient of the day, 2 centimeters, the third patient at the umbilicus, the fourth patient, 10 centimeters up. The camera port is the most important port in the surgery. And then the last port has to be placed low enough to allow you ease access to the root of the mesentery. Then your hands have to come from the side of the screen. Anytime your hands are coming from the top of the screen, your ports are too high. And I could watch a video and I could tell the surgeon is struggling because the hands are not coming from the side of the screen. Once your hands are coming from the top, that means you're doing this. It's very difficult to do. The hands have to be down and the instrument is coming from the side of the screen. Then the second thing is we talk about the free needle. The free needle can be looking at different angles. So it could be looking like the top at 9 o'clock or at 7 o'clock. And every location you have to learn on your own in a sim lab how to load and unload the needle to every single position on your own under no pressure. That's a skill you cannot learn in the operating room. It's just not fair to anyone. It's not fair even to the trainee themselves. So this is the part the person has to learn outside. Then when we have two pieces of small bowel with the mesentery in the bottom and want to put them together, a task many people do, we make sure that the person understands that the first stitch to put the bowels next to each other should not be at the anti-mesenteric border. Why? Because the real estate you work with is small. That first stitch has to be at 9 o'clock and 3 o'clock, so you have more real estate to work. Now, this is not something you can describe in the OR. This is something the concept you describe to someone outside the OR, so they know exactly what they're trying to do. Again, it's about the mental model. So when you come to the OR, you know exactly what you're trying to do. Now let's look at something else. Many of the residents have placed a stapler like this in the bowel. And then when they take the stapler out, they think the hole that's the common enterotomy looks like this. And the reality is it does not look like this. The common enterotomy looks like this. Where the cartridge is, there is a larger piece of bowel compared to where the anvil is. So whenever you put the stapler in the bowel, you need to recognize which part had the cartridge, which part had the anvil, because when you start closing, you'll make a difference. Let me explain. So if you think the enterotomy looks like in the left, you will put equidistant sutures, and you will think by putting equidistant sutures at the very end, the closure will be perfect. You just keep putting sutures like that, and when you finish, so basically you think you put equidistant sutures like this, and your closure will be good. Well, that's not the reality. The reality is the bowel looks like this. So one, you have to teach the person when they come at each angle, what angle should the needle be? And they need to learn this outside, because they cannot be learning this in the operating room. They need to learn how to load and unload the needle in each angle. Then they have to see an unedited video. And we have on our shared drive unedited videos of each procedure. I expect that before the person comes to the OR, they have to watch the video over and over and over, that they actually know exactly what the next step is, what needs to happen. So when they come in the OR, they're trying to replicate a mental model they have in their head. So again, going back to this analogy, if the person puts equidistant sutures like so, they end up with a dog ear and a leak. And it's like so consistent, because the bowel is like that. And what you need to do is the bites from 12 to 6 o'clock have to be wider than the bites from 6 to 12 o'clock. So when you end up with a good closure. Now, this is something you have to explain to someone before they start. So they need to have it in their head. And then when they come to the OR, they're just trying to replicate what they already have in their head. That mental model is key. If you don't have that mental model, it's very difficult to do it. Now, again, this is a quick video that explains what I was talking about. First stitch, not at the mesenteric border, but near the mesentery at 3 o'clock and 9 o'clock. You notice that the instruments are coming from the side of the screen. This is by design. And if you are not from the side of the screen, it's difficult. You always grab underneath where you're going to put the bite. You always make sure that the instruments are coming at a 45-degree angle. If this stapler is coming from the top of the screen, it's very difficult to handle. It's very difficult to do. So it's all about port placement. Then, when you suture, you are taking wider bites from 12 to 6 o'clock, and you're traveling more than 6 to 12 o'clock. So you have it in your head. You've learned some skills in the sim lab. So when you come into the OR, you are trying to practice some skills that you already have in your head. You're not starting from scratch. And I think that's the most important thing. The person can't just see what they're looking at. They need to understand first what they're doing, and then they come and try to practice this in the operating room. So this is, for instance, when you close the enterotomy. Let's look at, for instance, the area of doing the jejuno-jejunostomy defect. Again, this is a technique that when someone does, they need to make sure they're not tethering the mesentery of the rulum, because if you tether the mesentery of the rulum in the bottom, it's not going to work. So again, the same idea. The person needs to know what they're trying to close. They need to see it in the video. Then they need to understand that the most strong layer is the peritoneum, not the mesentery and the fat. So the bites have to be very, very superficial bites. And if you take superficial bites, you're getting what you need, and you're not going to get a hematoma. But the whole idea is, like for instance, you notice here, the person is taking the mesentery of the rulum. They need to understand that that's not where the bite needs to go. The bite needs to leave the mesentery of the rulum, because if you tether the rulum, you cannot bring it up. But the whole point is there has to be specific instructions. The person has to spend time on their own in the lab trying to replicate mental models they have in their head. But when they come to the operating room, they need to get constructive feedback, and they need to get time to practice it. It's very difficult if the person, you're assisting them all the time. So when the person is working, I am holding the camera and sitting in a chair. I'm not doing anything because I want them to struggle on their own, and they have a specific time. And if the person does not spend their time in the sim lab, it's going to take them longer, and they achieve less in that hour. So then the final thing is to close the jejuno-jejunostomy defect. And I think these two videos I showed you are the reason Roux-en-Y gastric bypass is becoming unpopular, because they're not easy to practice. And then the most important thing, which is something that Dennis Vergidis does very well, and we're trying to work with his group to do this, is we're trying to develop a cumulative sum analysis to objectively know how long does it take an average resident, for instance, to do the JJ. How long does it take a fellow to do the JJ? So then the person can know if they're improving and exactly where they are in the learning curve. So I think deliberate practice is a very important thing that we have to practice as surgeons that many other specialties have done. It can no longer be that training is just see one, do one, teach one. You have to have focused, deliberate practice that is objective, that has a coach. The resident has to know exactly that they need to practice on their own. Then there have to be actually specific goals. Has to be an educational environment for this deliberate practice to actually work. So I think the next time you see someone who looks very gifted, remember that it's not only about gift. There's a lot of practice in the motion. Thank you so much.